Welcome back to the deep dive.
Great to be here.
So today we're tackling something really quite serious, air embolism.
Absolutely. It's often called a silent hazard, right? Which is a pretty good description.
Exactly, and it pops up in places you wouldn't maybe first think of deep sea diving, okay, sure, but also like routine surgery, modern medicine.
That's the really surprising part for many, I think, the significant risk in clinical settings.
Okay, let's unpack this a bit. We're talking about an embolus. Now, the sources define that pretty broadly, don't they?
They do. Basically, any detached mass floating around in your bloodstream. Could be solid, like a clot fragment, could be liquid, like fat, or in this case, gas.
And it gets carried along until it gets stuck somewhere, causing trouble downstream, like infarction, tissue death.
Precisely. And our focus today is squarely on that gaseous mass. Air bubbles, or sometimes other gases, getting into the circulation.
So what happens then? Does it just float along as a single bubble?
Well, no, that's the kicker. It rarely stays as one neat bubble. What happens is these individual, often tiny bubbles start to, well, they merge, they coalesce really quickly.
They clump together, yeah, exactly. And they form this, the literature actually uses this quite chilling term, a frothy mass. A frothy mass. Wow, that doesn't sound like something you want in your arteries. It sounds less like a block and more like foam.
That's a really good analogy, actually. Think about trying to pump foam or whipped cream through a narrow pipe.
It wouldn't work. It'd just clog everything up, stop the flow completely.
And that's exactly what happens in the blood vessels. This frothy consistency, it just completely obstructs the flow, which means instantly you get ischemic injury downstream.
So the tissues served by that vessel start dying because they're not getting blood, not getting oxygen.
Immediately. It's like throwing a dam into the river. Perfusion stops.
Okay, so why is this specific issue, air embolism, or AE, why is it so critical? Why this deep dive?
Well, a few reasons. It's uniquely life-threatening because of how fast it can happen and how many ways air can actually get in.
Right.
And you don't always need a huge amount of air. A relatively small volume, especially if it gets in quickly, can be catastrophic.
Okay, volume and speed, we'll get into that.
Yeah. And the other key thing, which we touched on, is where it happens. People think divers, right? Gas embolism, the bends.
Sure, that's a classic image. But the sources really hammer this home. Iatrogenic causes, basically, medical procedures accidentally introducing air are surprisingly common. So this is a major concern in hospitals, in operating rooms.
The constant concern. It demands huge vigilance from surgeons, anesthesiologists, nurses, anyone managing lines or performing procedures. It's not just for the extreme sports crowd.
Okay, let's dig into that. The mechanism. How does air even get into what's supposed to be a closed system, the circulatory system? It seems like it shouldn't happen.
It does seem counterintuitive, yeah. And that's why the physics are so important here. The sources are clear. You need two things to happen at the same time for air embolism to occur. Two conditions. What are they?
First, you need an opening. Some kind of direct communication between a blood vessel, vein, or artery and the outside air or some other source of gas.
Okay. A hole, basically.
Yeah.
Essentially, yes. But just having a hole isn't enough. The second condition is the crucial one. You need a negative pressure gradient. Negative pressure, meaning the pressure inside the vessel is lower than the pressure outside.
Exactly. Lower than atmospheric pressure. And if you have that, the pressure difference actively sucks the air into the vessel, like a tiny vacuum cleaner.
Okay, but hang on. Veins have blood flowing through them. They have pressure. How can the pressure inside a vein drop below atmospheric pressure to create that suction? It often comes down to gravity or sometimes specific medical interventions. Normally, yeah, veins have a low positive pressure compared to the outside.
Right.
But if that open vessel happens to be physically located above the level of the heart, think about the weight of the column of blood between that point and the heart.
Okay, like water in a pipe. Hydrostatic pressure.
Precisely. That hydrostatic pressure can actually cause the pressure at the site of the opening to dip below atmospheric pressure. And bingo, you have your negative gradient. Air rushes in.
Okay, so the physical position of the patient matters hugely.
Hugely. And this brings us right back to those specific iatrogenic scenarios, the medical procedures where this risk is sort of engineered into the situation.
Like the neurosurgery example you mentioned, the sitting position.
Exactly. It's used for certain brain or spine surgeries, back of the head, neck area. The patient is literally sitting upright.
So the surgical site, the head, is way above the heart.
Significantly above the heart. Now imagine the surgeon is working deep near the dura mater, the lining of the brain. There are large veins there called venous sinuses, which are quite rigid. They don't collapse easily.
Okay.
If one of those gets accidentally open, nicked, you've got the opening, and because of the height difference, you've got a powerful negative pressure gradient thanks to gravity.
And the air just gets pulled straight in.
Instantly. It can be a massive, rapid influx. It's a known, calculated risk, which is why there's intense monitoring during those procedures.
Wow. Okay, what about things like catheters, central lines, stuff going into big veins?
Yeah. Any endovascular procedure, anything involving catheters, especially central venous catheters or CVCs, carries a risk, particularly during insertion or removal.
Oh, so during removal, the hole is closing up, isn't it?
Well, imagine removing a large bore CVC from a neck vein. If the patient is sitting up, again, gravity.
Negative pressure again.
Could be.
Yeah.
Or even if they're lying flat, if they take a deep breath in right at the moment the catheter comes out.
Inhaling decreases pressure in the chest.
Right. Drops the intrathoracic pressure, which can momentarily create that negative gradient relative to the outside air. If the opening isn't immediately sealed, air gets sucked in through the catheter left.
So technique is absolutely critical there, making sure the patient position is right, maybe having them hum or hold their breath.
Exactly. Procedures are designed to minimize that risk. Trendelenburg position, Valsalva maneuver, things like that.
You also mentioned laparoscopic procedures, keyhole surgery. They pump gas into the body for that, don't they?
They do, usually carbon dioxide, CO2. They insufflate it, pump it into the abdominal cavity.
Why CO2, not just air?
Safety, mostly. CO2 is much, much more soluble in blood than nitrogen, which is the main component of air.
Meaning, if a little bit gets into the bloodstream accidentally, the body can absorb it and get rid of it quickly.
Precisely. It dissolves, gets carried to the lungs, and you just breathe it out. It minimizes the risk of a persistent gas embolism compared to air.
But there's still a risk.
Oh, yes. Because they're using pressure to inflate the abdomen, right? To lift the abdominal wall and give the surgeon space to work.
Okay.
If that insufflation needle, the trocar, accidentally punctures a major vein during insertion, or if the pressure they're using to pump the gas in is set too high.
The pressure itself can force the CO2 into the vessel.
Exactly. Even though CO2 is safer, a large amount forced in quickly can still form a significant gas embolism and cause acute problems.
Okay. And lastly, you mentioned mechanical ventilation. That seems odd because that's positive pressure pushing air in. How does that cause air to enter the blood?
Normally it doesn't. In fact, positive pressure ventilation usually helps prevent air embolism by keeping venous pressure up. But if the patient already has some kind of lung injury, like a tear, a laceration, maybe from trauma, or even a complication from inserting a chest tube and there's damage to a pulmonary blood vessel nearby.
Okay, so there's a communication between an airway and a blood vessel within the lung itself.
Right. Then the positive pressure from the ventilator can actually force air across that connection from the alveoli directly into the pulmonary veins.
And pulmonary veins carry oxygenated blood back to the left side of the heart.
Which means those bubbles go straight out to the systemic circulation. Brain, coronary arteries, everywhere. That's an arterial gas embolism, and it's extremely dangerous.
So trauma is a big factor there too, like a major chest injury.
Yeah, a severe chest wall injury that tears a major vessel, combined with the person gasping or taking deep breaths, can definitely set up the conditions for air entry as well.
The potential scenarios seem, well, quite varied. Let's circle back to the volume. You said a relatively small amount could be dangerous. What's the actual deadly dose, according to the sources? Is there a number?
There are numbers, but they come with caveats, especially about the rate of entry. Generally speaking, for air to cause a significant clinical problem, just by accumulating in the pulmonary circulation, the lungs acting as a filter, you usually need a fair bit. The sources often cite more than 100 milliliters of air.
100 milliliter? Okay, that's what, like half a small cup? It sounds like a lot to get in accidentally.
It can accumulate slowly over a long procedure if there's a persistent small leak. The lungs can filter out small bubbles for a while, but eventually that volume just overwhelms the capillary bed. It physically blocks too much of the lung circulation.
Okay, so 100 milliliter as a sort of threshold for overwhelming the lungs.
Yeah.
But you mentioned speed being critical.
Hugely critical. This is a key point. It's not just about the total volume that gets in, it's about how fast it gets in.
How fast are we talking? The sources give a stark figure. Introducing a total of maybe 300 to 500 milliliters of air, but if it goes in at a rate of 100 milliliters per second, that could be fatal. 100 milliliters per
Yeah.
second. That's incredibly fast, like injecting it forcefully.
Or like having a large vein wide open to the air under significant negative pressure, like in that neurosurgery scenario, that kind of rapid influx.
Why is the rate so much more dangerous than just the total volume ending up there?
It's about fluid dynamics, really. When the air rushes in that quickly, the blood just doesn't have time to sort of buffer it or break it up.
You can't handle the turbulence.
Exactly. That rapid, turbulent entry allows those tiny bubbles to coalesce almost instantly into that big, single, frothy mass we talked about.
The foam.
The foam, and that massive slug of foam hits the right ventricle of the heart. The heart tries to pump it out into the lungs, but it can't. It's trying to pump air.
It creates an airlock.
Precisely. It causes what's called right ventricular outflow tract obstruction. The heart basically stalls. Circulation stops, leads to acute cardiovascular collapse, often before anything else can happen.
So the speed prevents any chance of adaptation or filtering. It's just immediate blockage.
Immediate, catastrophic blockage at the heart itself. That detail really underscores how sensitive the system is to rapid changes in flow, not just volume.
Okay, so we have this air, this froth in the system. We know the mechanical blockage is the first big problem. It stops blood flow, tissues starve. Is that the whole story?
Not quite. The physical blockage is devastating, absolutely, immediate ischemia. But especially when we're talking about smaller bubbles, microemboli getting lodged further downstream, particularly in the lungs, there's a second wave of damage.
Something beyond just plugging the pipe.
Yeah. The sources really emphasize this dual impact. It's not just mechanical, it's also biochemical, especially in the lungs.
Okay, tell me about the lungs. They handle gas all the time, right? Why are air bubbles in the blood vessels of the lungs so bad?
Well, when a significant number of these air microembolis get trapped in the pulmonary capillaries, the tiny blood vessels surrounding the air sacs, the body doesn't just see it as a blockage. It sees it as something foreign, something wrong, an injury.
So it triggers an immune response against the bubble.
Essentially, yes, an intense inflammatory response. The physical presence of the bubbles, maybe bumping against and damaging the vessel walls, the endothelium, that kicks things off.
What gets released? What happens in that response?
The damaged endothelial cells and maybe immune cells that rush to the scene start pumping out potent inflammatory mediators. We're talking powerful cytokines, things like TNF-alpha, interleukin-6, leukotrienes, the big guns of inflammation.
Okay, so a chemical cascade starts. What does that do to the lungs?
Well, these chemicals do a couple of things. They make the blood vessels leaky, increase vascular permeability. Fluid starts leaking out into the lung tissue. They can also directly damage the alveoli themselves, those delicate air sacs where gas exchange happens.
So the inflammation actually worsens the lung function on top of the blockage.
Exactly. You get pulmonary edema fluid in the lungs, you get more inflammation, maybe even acute respiratory distress syndrome, ARDS. So the air bubble doesn't just stop blood flow, it triggers this secondary self-inflicted chemical injury that makes breathing even harder and can lead to respiratory failure.
Wow. That connection, the physical blockage triggering a chemical meltdown, that's a really crucial point. It's not just plumbing, it's physiology reacting violently.
Absolutely. It shows how interconnected things are. Now, think about what happens if those bubbles get to the brain.
The central nervous system. Yeah, the brain needs constant blood flow. Doesn't tolerate interruption at all.
Not even for minutes. Neurons are incredibly hungry for oxygen and glucose. Cut off the supply for 3-4 minutes, and you start getting irreversible damage.
How do bubbles even get to the brain? Don't they get filtered by the lungs first if they enter a vein?
Usually, yes. If air enters the venous system, it goes to the right heart, then the lungs. The lungs should filter out most bubbles.
But sometimes they don't.
2 ways they can bypass the lungs. One is a direct arterial air embolism, like we discussed with positive pressure ventilation, forcing air into pulmonary veins. That goes straight to the left heart and out to the body, including the brain.
Okay, that's bad. What's the other way?
The other way is something called a paradoxical embolism. This happens if the person has a small hole between the right and left sides of their heart, like a patent foramen ovale, a PFO, which is actually pretty common.
So a bubble in the venous blood can cross over to the arterial side through this hole.
Exactly. If the pressure on the right side of the heart momentarily becomes higher than the left, which can happen with straining, coughing, or a large pulmonary embolism increasing lung pressure, the bubble can get shunted across the PFO, bypass the lungs entirely, and head straight for the brain or coronary arteries.
And when bubbles hit the brain circulation, what are the signs? What does that look like clinically?
It's usually dramatic and fast. Because the bubbles can block tiny arteries feeding very specific brain areas, you might see sudden focal neurological deficits.
Like what? Stroke symptoms?
Yeah, like sudden weakness in an arm or leg, vision loss, trouble speaking, aphasia, depends where the bubble lodges.
Oh.
But if it's a larger amount of air or many small bubbles,
It affects the whole brain.
it can cause global cerebral ischemia, leading to severe confusion, disorientation, seizures, or just, boom, sudden loss of consciousness, coma.
Rapid, severe neurological damage.
Absolutely. Getting air into the arterial circulation, especially to the brain, is one of the most feared complications. Okay, we've covered the iatrogenic side, the medical causes, quite a bit. Let's shift gears to the classic scenario. Decompression sickness, DCS. The bends.
Right.
The environmental hazard.
This is different, though, isn't it? The air isn't being sucked in from outside.
Exactly. The physics are sort of reversed. With DCS, the problem isn't air getting in. It's gas that's already inside your body tissues, dissolved harmlessly, suddenly coming out of solution and forming bubbles within the body.
Why does that happen?
It's all about pressure changes. Specifically, a sudden decrease in the surrounding atmospheric pressure.
Okay, so going from high pressure back to low pressure too quickly.
Precisely.
And who are the main people at risk for this? Obviously divers.
Scuba divers, deep-sea divers, absolutely. But historically, a major group was underwater construction workers.
The ones who worked in caissons. Those pressurized underwater chambers.
Yeah. Building bridge foundations, tunnels under rivers, they'd work under high air pressure for hours. The source material mentions these workers suffered terribly, both acutely and chronically, often without really knowing why back then. It was a huge occupational hazard.
So let's break down the science. What exactly is happening to the gases in the body when someone is deep underwater, breathing compressed air?
Okay, so you're deep down, the water pressure is high. You're breathing air from a tank, which is also at that high ambient pressure. Now, air is mostly nitrogen, about 80%.
And nitrogen doesn't really get used by the body, right? It's inert.
Right. But Henry's law tells us that the amount of gas that dissolves in a liquid is proportional to the pressure of that gas above the liquid.
Okay.
So under high pressure, deep underwater, your blood and body tissues, which are mostly liquid, start to absorb more nitrogen than they normally would at the surface. It gets forced into solution.
So your body fluids become super saturated with dissolved nitrogen.
Exactly. Especially fatty tissues, they soak it up. And
Yeah.
while you stay at depth, under pressure, it's fine. It's just dissolved, not causing any problems.
But then the diver starts to come up. The pressure starts decreasing.
Right. And if they ascend too quickly, if that pressure drops too fast.
It's like opening a shaken soda bottle.
Perfect analogy. All that excess nitrogen that was forced into solution suddenly has nowhere to go. It can't stay dissolved at the lower pressure, so it comes rushing out of solution, forming physical gas bubbles.
Bubbles forming inside the blood vessels, inside the tissues themselves.
Everywhere. And these aren't tiny microscopic bubbles necessarily. They can be macroscopic, large enough to cause immediate problems.
And this is what causes the acute symptoms, like the bends.
Yes. The bends is probably the most well-known manifestation. It's thought to be caused by bubbles forming primarily in and around the joints, maybe in the tendons, ligaments, skeletal, muscle.
Causing pain.
Excruciating pain, described as deep, boring, intense. The name itself, the bends, apparently came from the way sufferers would contort their bodies, arching their backs trying to find relief. It reminded people of a fashionable posture at the time called the Grecian bend.
A grim name. So joint and muscle pain. What else can happen acutely? You mentioned the chokes.
Yeah, the chokes refers to the pulmonary effects of DCS. This is when a large number of nitrogen bubbles form in or travel to the lungs' blood vessels.
So like an embolism, but from internal nitrogen bubbles overwhelming the lungs.
Exactly. It causes irritation, inflammation, fluid leakage, basically pulmonary edema, maybe some hemorrhage, maybe areas of lung collapse, that's focal atelectasis.
Leading to breathing problems.
Severe respiratory distress, shortness of breath, coughing fits, chest pain. It's a serious life-threatening complication because it directly impacts your ability to oxygenate your blood.
Okay, so those are the acute dangers. Pain, breathing problems. Yeah. What if someone survives that initial hit, gets treatment? Are they in the clear or are there longer-term issues?
There can definitely be long-term issues. This leads to the concept of caisson disease, which is essentially the chronic form of DCS, named after those tunnel workers.
What happens chronically?
Even if the big acute bubbles are dealt with, smaller bubbles or maybe the effects of repeated mild exposures can cause problems over time, particularly in bone.
Bone. Why bone?
Bone marrow is quite fatty, and nitrogen dissolves well in fat. Also, certain areas of bone don't have a great blood supply, so gas emboli, even small ones, can persist there or form repeatedly.
Causing damage over time.
Yes, leading to ischemic necrosis. Basically, areas of bone tissue die off because their blood supply keeps getting interrupted by these persistent or recurring gas bubbles.
Bone death. That sounds bad. Where does this typically happen?
It often targets the ends of the long bones, especially the weight-bearing joints, which have large marrow cavities and maybe... The classic sites are the femoral heads, the ball part of the hip joint, the upper part of the tibia shin bone, and the humeri upper arm bones.
And what's the result of that bone dying off?
Over time, the dead bone can collapse, leading to severe arthritis, joint destruction, chronic pain, and permanent disability. And this can happen years after the person stopped diving or working in compressed air. It's an insidious, long-term consequence.
Okay, so whether it's DCS from diving or a big air embolism during surgery, the immediate problem is gas bubbles obstructing blood flow. What's the treatment? How do you fix it?
The primary immediate treatment, especially for DCS, but also applicable to severe arterial gas embolism, is recompression.
Putting the person back under pressure.
Exactly. Get them into a hyperbaric chamber as quickly as possible. The increased pressure physically shrinks the gas bubbles, according to Boyle's law.
Smaller bubbles cause less obstruction.
Right. And crucially, the high pressure also helps force the gas, primarily nitrogen in DCS, back into solution in the blood plasma, where it's harmless again.
So you're basically reversing the process that caused the bubbles in the first place. How high does the pressure need to go?
It depends on the situation, the severity. Treatment tables exist, but often initial treatment involves recompressing to the equivalent pressure of, say, 60 feet of seawater. That's about 2.8 times normal atmospheric pressure, ATA. Sometimes even higher for very severe cases, maybe up to 6 ATA.
And they just stay at that high pressure. For a period, yes, to allow time for the gas to fully redissolve and for oxygen to start reaching the damaged tissues. But then comes the critical part, getting them back to normal pressure safely. Oh, you can't just bring them up quickly again, or the bubbles will reform.
Precisely. So after the initial high-pressure treatment, they undergo a very slow, controlled decompression, following specific schedules, often lasting hours.
Why so slow?
To allow that dissolved nitrogen or other gas to come out of solution gradually and safely. It gets transported by the blood back to the lungs, where it can be breathed off, exhaled, without forming obstructive bubbles again. It's all about managing that off-gassing rate.
Okay, so recompression therapy is the cornerstone. That basic principle hasn't changed much, has it?
The principle, no. Put them under pressure, bring them back slowly. But how we manage and prevent AE, especially the iatrogenic kind, and how we optimize treatment that has evolved.
Right, let's bring in some of the updates, things verified from current practice and research. How has the recognition of iatrogenic risk changed things in the hospital?
Well, there's a much, much higher awareness and focus on prevention. Knowing those two key conditions, communication and negative pressure gradient protocols, are now built around avoiding them.
Can you give examples, like in neurosurgery, if they have to use this sitting position?
Sure. Besides intense monitoring, anesthesiologists might use PEEP positive end expiratory pressure on the ventilator. Keeping a little bit of pressure in the lungs at the end of each breath helps keep the central venous pressure slightly elevated.
Counteracting that gravitational negative pressure.
Exactly. Surgeons are also incredibly meticulous about sealing any potential venous openings immediately, using bone wax, clips, constant irrigation to keep vessels collapsed or covered. It's proactive defense.
And for things like CVC line removal.
Strict protocols. Patient positioning is key. Usually Trendelenburg, head down, feet up, to increase venous pressure in the neck and chest. And coordinating the removal with the patient's breathing, often having them exhale or hum during the pull, again, to raise intrathoracic pressure and prevent air sucking in.
So lots of focus on just stopping the air getting in the first place.
That's always goal number one.
But if it does happen, or for DCS, you mentioned hyperbaric oxygen therapy, HBOT, we know the pressure shrinks the bubbles. What about the oxygen part? Why breathe 100% oxygen under pressure?
That's where the therapy gets really clever. It's not just mechanical pressure. Breathing pure oxygen at, say, 2.8 atmospheres massively increases the amount of oxygen dissolved in your blood plasma.
Are we more than usual?
Exponentially more. Now think about that nitrogen bubble stuck somewhere. Inside the bubble is mostly nitrogen. Outside, in the super-oxygenated plasma, there's hardly any nitrogen but tons of oxygen.
You create a huge concentration difference.
A massive gradient. And physics dictates that the nitrogen will rapidly diffuse out of the bubble, following that gradient, into the plasma to be carried away.
So the high oxygen literally speeds up the removal of nitrogen from the bubble, helps it dissolve faster.
Yes, it dramatically accelerates bubble washout. That's the term. Plus, that superoxygenated blood can deliver much-needed oxygen even to tissues whose blood supply is partially blocked by the bubble, helping to combat the ischemia and potentially reduce that inflammatory response we talked about.
So HBOT is doing double duty, shrinking the bubble mechanically and washing out the gas chemically, while also treating the tissue damage.
Exactly, which is why getting the patient to a hyperbaric chamber quickly is so incredibly vital. Time is tissue, especially brain tissue.
Given how dangerous even small amounts of air can be in surgery, how has detection improved? Can we spot it earlier now, before it becomes a massive problem?
Yes, this has been a huge area of advancement. Relying on clinical signs like a sudden drop in blood pressure or oxygen levels often means a significant amount of air has already entered. We needed earlier warnings.
So what tools provide that?
The big ones used in high-risk surgeries are transesophageal echocardiography, TEE, and precordial Doppler ultrasound.
Okay, ultrasound. How does that pick up air bubbles?
Air is very different from blood when it comes to sound waves. Gas bubbles are highly reflective.
So they show up brightly on the screen.
On TE, yes, you might see a shading effect or even discrete bubbles crossing the heart chambers. With the Doppler probe, which listens for blood flow sounds, placed over the chest.
Sound different.
Dramatically different. Even tiny amounts of air entering the right heart create a very characteristic sound change, often described as a gurgling or classically a mill-wheel murmur. It's loud and unmistakable to the trained ear.
So the anesthesiologist gets an immediate audio warning, or the surgeon sees it on the T.
Instantly. Long before enough air has accumulated to cause hemodynamic collapse. It allows the team to react immediately, alert the surgeon to flood the field, change patient position, manage pressures, and stop the air entry while it's still a minor event.
That early warning must be crucial.
It's life-saving. It turns a potential catastrophe into a manageable incident. This kind of real-time, sensitive monitoring is probably the biggest leap forward in managing iatrogenic AE risks safely.
Okay, let's try and wrap this up. To summarize this deep dive then, air embolism. It's this really quite insidious risk. It's present in extreme environments. Yes, the divers, the caisson workers.
But it's also a constant hidden threat lurking within modern medicine. Surgery, critical care procedures.
And the danger comes from two main things.
Right. First, the straightforward mechanical blockage, the frothy mass, the foam obstructing blood flow, causing immediate tissue damage from lack of oxygen.
And
Second, the biochemical assault. The inflammatory response triggered by the bubbles themselves, especially in the lungs, which adds insult to injury and can lead to widespread organ dysfunction. And remember, the speed of air entry is often more critical than the sheer volume.
it really highlights how vulnerable our circulatory system is, doesn't it? Whether it's nitrogen bubbling out under low pressure or air being sucked in under negative pressure.
It's a powerful demonstration of how even seemingly small physical disruptions, just gas bubbles, can cascade into total systemic failure by hitting both the plumbing, the circulation, and triggering this intense chemical overreaction. The body just isn't designed to have gas flowing through its pipes.
It really makes you think. Which brings us to our final provocative thought for you, the listener. We know iatrogenic AE is common, and we know the body is incredibly sensitive to gas where it shouldn't be. So looking ahead, how might advances in technology that minimize or even eliminate direct contact with the bloodstream during procedures change this risk?
Things like more advanced robotics, minimally invasive techniques that are truly closed loop.
Exactly. Or perhaps imaging technology so advanced they could detect a potential vascular breach before it even happens, allowing surgeons to avoid it entirely. Could these kinds of innovations ultimately eliminate the risk of these accidental life-threatening bubbles in the future?
It's certainly the direction things need to head. Reducing that point of communication, that vulnerability between the inside and the outside world during medical care, that feels like the next major frontier in tackling this specific and very dangerous problem. Constant innovation and a deep respect for the simple physics of flow seem key.
A fascinating and slightly terrifying topic. Thanks for walking us through it.
My pleasure. Important stuff to understand.